Hello, everyone, and thank you for joining us in this webinar series. Um, my name is Malachi Charbonneau. I'm the general manager here at Medaptis. I'm joined with a couple of our colleagues, which I'll introduce in a moment here, but happy to be speaking with you all. We're going to be going over a topic today that seems to be being done across health systems and different platforms all over the country. And that's whether or not you're wanting to customize your EHR workflows, and if they're going to do it via a do-it-yourself solution or through a vendor partnership. So we'll talk a little bit about the pros and cons to each one of those situations, and then kind of delve deep into different scenarios where it may make sense for both here. So just a little bit about us, Medaptis. We've been in business for around 24 years, provide software solutions for healthcare systems, large health systems and physician group practices. We really specialize in areas that are typically underserved but high value. So I actually have a lot of experience, working and integrating directly with the EHR, trying to fit into areas that they don't specialize in, creating workflows that are customizable in those areas. Typically have a pretty significant return in workflow process improvement with our solution base. So I've already introduced myself. Once again, I'm Malachi Charbonneau, General Manager here at Medaptis. Jeff, you want to introduce yourself?
Sure, thanks. I'm Jeff Sabati, Senior Implementation Consultant for Medaptis, and I have a little bit more focus on our clinical application, which you'll hear about in a little bit, which is our Assign application, which essentially is going to match the correct providers to the correct patients. And you'll hear about what we learned in the field and how we can do it with our software. Thank you.
Great. Thanks, Jeff. Gary?
Thanks. My name is Gary Burnflow, and I'm the Senior Product Director here at Medaptis, focusing lately more on our automated infusion charge product, which, again, you're going to hear about just a little bit. And I've been with Medaptis for about 17 years now.
Great. Thanks, guys. So today's agenda, we'll go through the do-it-yourself solution versus vendor partnerships. Jeff will walk through that clinical operations example for automating patient assignment workflows, and Gary is going to talk a little bit about revenue cycle space around infusion auto coding. Then we'll have some time for questions and answers. So as we talk about do-it-yourself solutions versus vendor partnerships, we're really talking about customizing your EHR and working with your EHR vendor to be able to create customized and custom coded solutions to meet your specific workflows. There are some scenarios still where folks are still building their own software, but I think that's becoming less and less. And they're either trying to kind of work with what you have in a manual way or augment it with some type of customization within your EHR, or partnering with a vendor to meet your needs, whatever that may be. If it's workflow improvement, if you're trying to automate something, or add some more, clinical intelligence to what you're trying to do. So in all of this, the EHR was designed to do documentation, is bridged into revenue cycle. Obviously, there's clinical applications as well, like pharmacy and different modules within those applications. But really, for workflow improvement areas, they're still a little bit, dragging behind, and have been able to kind of makeshift different solutions in those areas. But those are some of the opportunity areas to maybe look at from a vendor partnership perspective, especially when you get into areas that are high value. And when you talk about scaling those things up. So just some evaluation factors. We're not the first to talk about this as far as, build versus buy, right? Or even customize versus buy. So when we're talking about, how quick do you need this solution? The deployment time is a factor, depending upon what your IT bandwidth is within your organization. That how much they want to actually customize their existing infrastructure. Some organizations don't want to kind of go outside the bounds of what is quote unquote standard. This could take anywhere from 6 months almost to 2 years, or maybe never get done. So deployment time is definitely a factor in making sure that you can get the solution that you need in the way that you need it in a timely way. You can also talk about long-term vision. So as you're looking to solve these challenges, either workflow bottlenecks or specific areas that you want to improve upon within your organization, you're fixing that point solution, but there's also other contributing factors outside of that, and other areas that spills into that don't really get addressed. So you're fixing one piece, but not really addressing the whole item. So if you're looking at kind of a long-term vision from a do-it-yourself solution, you're really just fixing that one piece and not having a roadmap to, continuous process improvement. Moving on to just cost. There's certainly cost when it comes to partnering with a vendor, right? You have to make sure you have the right return story associated with that, but also there's kind of some hidden costs with your do-it-yourself or customized solution within the EHR. That comes with the maintenance costs of that over time. And also your IT bandwidth of being able to get that done over time as well. So where you will be spending money with a vendor, you will be spending resource, time, cost, and if you're having to partner with the EHR to create that customization, there's typically costs associated with that. Now moving on to just knowledge base and IT focus. So I think one of the major benefits that you get with partnering with an IT supplier or vendor is getting the knowledge of that organization, but also all the other organizations that they've worked with before in the past and will work with in the future, to make sure that they're transferring that knowledge down to you. They're incorporating that into their product base. So you're gaining some benefits and you're not misstepping as you're doing your implementation. We'll talk about a little bit in the examples, but having somebody who's done it repeatedly over and over again, that time to delivery will be faster. And also you'll gain the benefits of all the other things that other customers have learned over time. Just kind of moving on to the customization and scalability. The continuous customization, like I said, when you're doing your do-it-yourself kind of program or partnering with the EHR to fix something, you typically do it once and don't touch it again. And it may meet your needs initially, but how do you continue to improve upon that over time? Partnering with a vendor, they have to have the ability to customize their product to meet your workflows. That's kind of a must, right? And they have to meet your requirements on what you actually need to accomplish. But then over time, the vendor is probably going to be more suited to be able to continue to customize as your environment changes and you need to add different areas to that product line. The vendor is going to be more suited to do that than that point solution from the EHR that you customized. And then lastly, just scalability. As you fix these problems and there's bottlenecks, say in one facility or one specific area, if you're doing it with an EHR customization, it works for that specific area. But how do you have a program that can work across your enterprise? If you want to scale that, if it makes sense to scale that workflow, you're going to have to do those point solutions in each of the different areas if it's not, reviewed internally at the beginning. So choosing a vendor for scalability in an enterprise application is important. And it just gets into that, making sure that they can meet the requirements and that configurability or customizability of that application to meet all the different subspecialty areas, the facilities, the workflows of the institution in all those different areas. I thought this was a pretty good quote. Like I said, we're not the first to think of this, but this came from a healthcare IT news article as we're kind of researching this topic a little bit more and making sure that we, had our head on straight. But we're really, those homespun programs, I thought this was really good. Really nothing more than a mishmash of manual workarounds to accommodate a growing set of deficiencies. And I think that speaks to kind of what Gary and Jeff will go through and what we've witnessed over time, shadowing a lot of different organizations where you think you've created some type of workflow or customization, you start to add spreadsheets and manual process. You hope to train folks. There's a lot of turnover. So you just start to introduce all these, manual errors in that workflow. And it eventually kind of destabilizes the whole process. So I thought this was a pretty good kind of snapshot of what we're talking about today. All right, I'm going to pass it over to Jeff Sabati. He's going to talk about the clinical operations example.
Great. Yeah, thanks, Malachi. And as he alluded to, we always like to say it's not that the EHRs can't do what we're talking about here. It's just that they may not do it well or perfectly. And that's really why we're in business as a third-party vendor that you may be looking to purchase is, the first thing we want to talk about, part of this clinical operations is one of our offerings, which is Medaptus Assign. Just in a nutshell, what we do for those who may not know about this product line, we intelligently assign patients to providers. We mainly focus on the hospitalist medicine group that has the biggest turnover of new assignments and patient assignments each day. They need the most help, so that's what we focused on, and that's essentially what our product does. So what we've learned in the field is really what I wanted to start with, and why someone would go with a vendor versus trying to figure it out themselves within your Epic, your Meditech, your Cerner, whoever it may be. We've looked at current states. We do this in the sales process, in the implementation process, in the customer success process with our current clients. It is really, what are they doing now? They're doing a host of spreadsheets and trying to figure out what patients need to be seen by what provider each morning. Trying to get that information into the EHR or using the limited technology in the EHR to do the assignments are really what we're seeing. We've had some hospitals tell us, they're going to build their own system, but as Malachi alluded to, that's an undertaking of its own. You need to hire developers and maintain it themselves. So I'll talk a little bit more of exactly what I've seen, and then we'll move on to the next slide. So here's just a quick snapshot. And for those who are on the call who may be part of the assign process or have done the assign process, this may look familiar to you, is listing out the providers that are working each day from your schedule, how many patients they had yesterday, how many new patients they have today, spreadsheets, which are on your left-hand side, or using some team concept in EHR as well. I got this team red, team blue, team green, and just manually filling it out each morning. Trying to, workload balance, maintain continuity, get rid of your discharges. I could go on and on about, what I've learned that has to be done each morning, but it's pretty cumbersome. And this is just a snapshot of some of the manual processes that we've seen and documented. So how long does this all take? That's really the first question we get or we talk about during the sales process. There's some labor burden going on here, hence why a client is looking for a vendor to solve this problem. We have a lot of other pieces of our ROI, but we also, we usually first talk about the labor savings. This is a 1 to 3 hour process that happens with a lot of these groups in the morning. Again, they're trying to figure out all the patients in their hospital and on their census and which providers need to round on them. We have clients from, I think, 70 patients all the way up to 600. And surprisingly, all of them take time. Obviously, the larger the census, probably the more of a labor burden this is. But it takes a while to get this done. Providers need to usually start their day at 7 a.m. They usually work a 12-hour shift. So someone is starting this process at 5 a.m. often to get this out the door. And again, here are just some more screenshots of what we're seeing from the Epic treatment teams to the Cerner power chart, et cetera. So here's kind of what I call like a word bubble or some of the keywords and phrases that we see that I've jotted down throughout my experience here being a solution consultant? What are the softwares that are being used to do the clinical assignment process? And what are those human skills that have to happen as well? And how we come in and try to take away at least some of this. So we've talked about this now throughout, whether it be the Epic treatment teams, the Epic care teams that you have to go update each morning directly in the EHR, Grand Central being their registration. Cerner Power Chart is their version of a team-based concept, Meditech registration, all the way down to like bare bones exported Excel spreadsheets I've seen used as well. Those have to be saved and hopefully don't get erased because they are used from day to day to do a comparison. And then when I've been on site for a lot of these hospice programs, we've seen simple as pen and paper, writing things down on whiteboard. Hey, we have X amount of patients that are left off from the nocturnist team that are going to need to see. Printouts, the dropping off face sheets to the list maker, calculators, tallying. As you can see, it's a pretty in-depth, laborious process. And where I want to end things, and we can send this out after the presentation, is just to show you like our expertise in this area. We know about the major processes that happen during the patient assignment workflow, and that's validating the census each morning, running the schedule, seeing who's on schedule, running the assignments, and then finally creating those rounding lists and get them out the door to your providers so they can get back to patient care, because that's really what's important here. We talk about in this middle column, the manual process that we've seen and documented. And then where you'll probably be interested is that future state, this automated workflow that you could get with Assign. So really going from the middle column to the right column is where you're going to see the benefit of our product. I'm not going to go through every box here, but I just want to let you know it's here and that we've documented this workflow for you. So that's the Assign piece. I'll hand it back to Malachi and he'll give it off to Gary.
Yeah, thanks, Jeff. Appreciate that. We're going to introduce Gary Bernklow. He's going to take another example kind of driven approach from the revenue cycle side for infusion auto coding.
Thanks, Malachi. Yeah, as Jeff noted, we also have some expertise in infusion billing. We have a specific system in our part of our charge capture product called the infusion charge product. And what we're doing is we're looking at outpatient infusion coding and billing. And I'm not sure how much folks understand this, but it's a rather complex kind of subdivision of outpatient coding. And the reason it's so complex and it's so difficult for organizations to do correctly or to do accurately is that it's not kind of a one-to-one, we did this service, therefore it's this CPT code, right? Excuse me. Each one of the billable units that you have to associate with an infusion service is time-based. So you get one unit for the first 60 minutes, another unit for an additional 60 minutes. And in addition to being time-based, it's got a rather complex hierarchy of drug types that have to be accounted for. So chemotherapy drugs, therapeutic drugs, and hydration drugs. And there's a very strict hierarchy in which those have to be charged as well. And there's a bunch of, kind of rules for overlapping times, drugs that are administered, at the same time as others, or drugs that are mixed in the same bag. There's rules for those. And to top it all off, oftentimes the documentation may not be complete. And so what we've seen typically for organizations is they try to address their infusion coding in a couple of different ways. And one way is to throw nurses at it because they're the ones on the front lines capturing this documentation, but they don't really want to be coders. So they don't like doing it. Or the other way is to assign a bunch of coders to evaluate each and every infusion service to make sure it's built accurately. So I mentioned that it's made up of very complex data and very complex rules to do infusion services, right? within the rules themselves and the infusions themselves, each one of these infusion services has a bunch of different, what we call events here in Medaptis. And each one of those events have to be calculated into the billing codes. You have a start, a stop, a new bag, a paused, a restarted, a given. All of these are specific events for drug administrations that all have to be accounted for. And you can see, various types of potential EHR here. You have given, missed, reduced, canceled, pulled, new bag, restarted, stopped. All these are, like I said, events that have to be accounted for in the final billing. So it makes for determining the correct start and stop times for an infusion, the correct duration of an infusion, which you need in order to bill correctly. It makes it very difficult. And behind, in the background there, you can see kind of one example, each one of those line items. This is a chemotherapy protocol that was delivered to a patient. It's not an unusual one. It is fairly complex, but it's not unusual. This happens all the time. And each one of those line items represents one of these events that I'm talking about. So you're asking a coder to make sense of each one of these events. Obviously, the data would look different in the EHR, but each one of these is an event. The coder has to make sense of them, put them in the right hierarchy, correct for overlapping time. It gets very confusing very quickly. And so we tried to develop a product that reduces that. I'm going to talk about that. So when we first put together our infusion product, it was actually a manual product. You would type in a start and stop time and a drug, and the system would come back and tell you what the code should be. And we thought, well, that's kind of double entry, right? If you have nurses who are already entering in, or clinical staff who are already entering in those values into the EHR, it would be much easier if we could just pull that data directly out of the EHR and calculate the codes based on that direct information. That way you have kind of 100% compliant codes, right? Based on what your documentation is. So we set about creating what we call our infusion charge capture. And this is what we found when doing it. We did get some feedback from several of the larger EHRs saying, oh, we already do that. But what we found was what they're doing is they're coming up with a list of recommended codes, right? It's kind of looking at text that you've entered into the system, and it's going to recommend some billable codes, but it doesn't really do the math. It doesn't really, calculate each code specifically for each event. So there were some deficiencies there in some of the EHRs, and so when we compared what we did to build this product with what's available in the EHRs, or what could be customized in some of the EHRs, this is what we found. We needed full-time programmers. We built this system over the course of 6 to 12 months. That's how long it took us to build this. And we're experts in the charge capture area. So someone who's not an expert in the charge capture area may do it longer. We figured it would, you need to provide some end-to-end testing. You have to account for multiple departments. And cost and resources is pretty large. We spent a lot of money building this application. More than 2,500 hours of programming. We have to have server space for all the data that we get. If we were going to integrate with smart pumps, there were probably fees or integration to be done with those. And those are pumps that send infusion data directly into the EHR, so you can pull it right from there. There's a training program that you have to figure out, right? If you're going to create this application, you have to train all of your users on how to use it, and even then, maintain your knowledge base and maintenance and making sure your training is up to date, right? And talking about internal knowledge base, you have to account for what we call outlier situations. And those are things that maybe do not fall specifically under the infusion outpatient coding rules, but are typically done in an infusion department. And you want to account for those. You don't want to do just one kind of micro section of infusion departments and ignore the rest of those charges. So if you're thinking about doing this or building this on your own, keep that in mind as well. Things like transferring departments. If a patient is admitted to the ED and then is then transferred to the OBS, does your hospital require that the charge master codes for those two departments be different? If they cross midnight, the dates of the units that you're billing have to be different. Those are all things that have to be considered as well, and things that you may not think about initially when you're starting to build something like this. And one of the things that we do want to implore people to think about is what we call the lottery factor. And that's, maybe you have one person who really knows your workflow really well. What happens if they win the lottery and quit their job? You kind of lose that knowledge that you have in your system. For customization and scalability, how easy would it be to add new departments? How easy is it to maintain your drug identification codes? So one of the ways we identify drugs is either a chemotherapy, therapeutic, or hydration drug is based on NDC codes, and there are 15,000 of those, and they increase daily. CMS maintains a crosswalk that is not 100% accurate and needs to be manually worked pretty much monthly. So you have CDM changes also that may be taking place in your hospital CDM codes. If a code changes or a new department's added and there are new codes. So these are all things that you have to keep in mind when thinking about building this specific product. As opposed to, kind of automating using Medaptis and Fusion, right? A lot of times your EHR data is going to be compartmentalized. So we pull data right now. For instance, we have an Epic client, and we pull data out of the Epic EHR, but the data doesn't sit in one spot. We had to research where it was, find it, and be able to manipulate it so that we can pull the data the way we need to. We pull out of the pharmacy system, the registration system, other clinical data, appointment system, your admission data, patient demographic areas, everywhere, just to make sure we can get the complete information for one infusion. You want to think about multiple drugs. What happens if a patient is issued multiple drugs which were mixed in the pharmacy in one bag? You can only charge for one of those drugs if it's going through one bag. Which drug do you use, and how do you identify that? Again, just complexities that you may not think about when you're just thinking, well, there's start and stop times in the EHR. Let's just use that data. It gets much more complex than that. And infusion is not the special case in that regard. A lot of things are much more complex in the data than you think. As I mentioned, how are your drugs identified? We can do it either using HitFix codes or NDC codes. But you also have to maintain that kind of crosswalk system, right? So you'll constantly be adding HitFix codes or NDC codes or, RxMed code, codes if you're using those to identify specific drugs. So those have to be maintained, and they have to be maintained constantly. And I did mention, how does your system handle drug administration that continues past midnight? It requires multiple units for a patient that transfers from the ED to OBS, but each one of those units were started on different days. They each have to have a different data service, but it's still one encounter. So how do you handle that? So those are, kind of the big complexities that you have to deal with. So what we've seen with the automated infusion coding, for instance, this application that we've created was an 80% productivity increase. And by that, we mean prior to going live with Medaptis, coders or nurses or somebody needed to review each and every infusion service to make sure it was coded accurately. It required 5 to 10 minutes per service to make sure that was done. If you automate it using data that's already in your EHR, you can reduce that. Our goal is 80 out of 100 claims go directly through back to the billing system 100% accurately. So that's fully compliant. You can expect a 15% revenue improvement. And the reason for that has to do with, defensive downcoding. Essentially, if you're asking a nurse to code things, she's going to defensively downcode, the services she's providing. And like I said, since we're pulling data directly out of the EHR and the billing matches what's in the EHR exactly, you're going to be 100% compliant with your charges. Your nurses are going to spend less time coding. You're going to leverage your existing systems and not have to maintain any new ones.
Great. Thanks, Gary. I think we're at time almost here. Let's open it up to questions here. Let's see if I can get to the Q&A section. Here we go. All right, here's one. Our workflow is very unique. How does Medaptis handle so many different complex workflows? I think that hopefully came through with what Gary and Jeff went through today. You have to choose a vendor that really understands the specific area you're working with. And you really have to have some discovery conversations with them around those specific requirements. I think we've worked with a lot of folks where the initial conversation is there's no way you could possibly do what we're doing manually in an automated way. And then we kind of talk them through the process, who we've worked with, get to understand their workflows, and then also make sure if we're going to partner with somebody that we truly can deliver based upon the complexity in the areas that they work. A nice thing about our organization, we work in very specific areas where we've learned a lot of that, how those workflows happen over time with many different groups. So, it's not a siloed information base, but we've gotten it a lot from our customers here. All right. I don't know if we can get to any more questions. I think we're at time here, but I appreciate everyone joining the webinar today. Definitely feel free to connect with us. You can email myself, Malachi, Jeff, Gary, follow us on LinkedIn to see kind of what we're working on next. But also we're always open to kind of understanding your challenges and different areas that you think we may be able to help you either in the clinical setting or in the revenue cycle space, whether that's patient assignment or infusion or something else. So, but thank you all for your time today.
Thank you.
Hope to hear from you. Thanks.